Okay, good afternoon, everyone, and welcome to this month's APA Practice Organization webinar, Geropsychology Practice, A World of Opportunity. Thanks for signing up to attend. This webinar is organized by the APA Practice Organization, a legally separate companion organization to the American Psychological Association that advocates for psychologists on reimbursement issues. I'm Julie Ashman, and I'll be moderating today's webinar. And I'm happy to be joined by today's presenter, Dr. Michael Frise. Dr. Frise is a clinical geropsychologist in private practice in Los Angeles. He is also a consultant for several medical facilities in the Los Angeles area. Dr. Frise is an active member of APA, the California Psychological Association, and he's on the board of the Alumni Council at Palo Alto University, as well as the board of directors of the Los Angeles County Psychological Association, where he serves as a board representative to the California Board of Psychology. Before he starts his presentation, I'd like to cover a few logistics. Everyone is currently in listen-only mode. So if you have a question, please type it into the chat box. You can also email your question to practice@apa.org. And just to note that this webinar is being recorded, so we will email you a link to the recording when it's finished. There will also be a survey to take about the webinar. Okay, so I will now turn things over to our speaker, Dr. Frise.
Good morning, everyone. It's a pleasure and a privilege to be giving this webinar this morning. As Jules said, I'm a clinical geropsychologist, and I have a private practice that is facility-based in Los Angeles County. And so today I'm going to be talking about my practice, a little bit about how I got started, and over the past 7.5 years, what I have learned that has worked so that I can pass that on to all of you who might be interested in having a mobile Medicare practice. This webinar is designed for those interested in running an independent psychology practice without managing an office. It's for finding steady work in assisted living facilities as well as skilled nursing facilities, exploring opportunities to work as a consultant in a medical setting, and working part-time and making a full-time income with minimal expenses, which for most people, some of these concepts are rather foreign. So let's begin. The first thing that I did when I realized that I wanted to go into private practice, and more specifically have a facility-based practice rather than a brick and mortar or an office setting, was I did some research to find out how I could locate facilities, first of all. Now, obviously, driving around town, you might see skilled nursing facilities or assisted living facilities, but you may not know how to reach out to them. How do you get the proper contact information for the people that actually run the facilities? And what I have put on this slide is specific for California, but I believe it could be consistent across the country, which is that skilled nursing facilities are regulated by the Department of Public Health here in California. And I've included a link to that website. If you were to go to the website, you could look up facilities by location or by name. So for example, if you drove by a facility and you wanted to get the contact information and you had the name or the address, you could do a search and get that information. Similarly, with assisted living facilities, the Department of Social Services regulates and licenses them here in California. And I've listed the link to the Department of Social Services, and very similar, you could search by location, zip code, street address, or facility name. These websites list, the contact information for those in charge of each facility, but they also list some very important information that you will be interested in, which is the number of beds in a facility, as well as the complaints filed against the facility and any investigations. For skilled nursing facilities, they also list survey deficiencies, which are really important if you are going to be associating your name and reputation with a facility, it's important to do your homework and to know a little bit about the facility other than where it is and what it looks like. Over the years, I have been in several facilities, and over the years I have learned that sometimes it's better to do your homework than to just go and present who you are and what you have to offer. Because again, your name, reputation is going to be associated with a facility, and it's better to be associated with the ones that don't have a lot of deficiencies and or plans of correction, all of which are public record. With regards to contacting the facilities, for skilled nursing facilities, typically it's best to contact the administrator directly, unless they have a medical staff and credentialing office that handles bringing consultants on board into the facility. So for example, the Los Angeles Jewish Home, which is a rather large organization, has a medical staff and credentialing office that brings in all of the outside allied healthcare professionals or Medicare Part B professionals, such as psychologists, audiologists, podiatrists, dentists, and you have an application packet that you fill out and turn in, and then they do a background check, Department of Justice check, fingerprint, as well as checking references. And at the Los Angeles Jewish Home, it actually goes before the board of directors for an official medical staff appointment as a consultant medical staff member. With regards to assisted living facilities, it's best to reach out to the executive director, who is the equivalent of an administrator at a skilled nursing facility. Assisted living facilities go by a couple of different names. Sometimes they're referred to as residential care for the elderly, or RCFE. And I would contact the executive director unless you know by virtue of either the website or by knowledge that there's a director of wellness, because my experience in several assisted living facilities that I have been in is that the director of wellness really manages all of the ancillary services, as the ones I just mentioned: psychology, psychiatry, podiatry, dentistry, optometry, audiology. And so the director of wellness may be the person who then brings people on board. But long story short, it doesn't hurt to go directly to the top, but sometimes the administrator and executive director will then forward your email to another staff member that would be able to help you. Once you get your foot in the door, it's really important to know how to sell your services to the facility. And what has happened, in particular in Southern California over the past several years, is that in the facilities that I have been in, there have been groups that have been coming to sell their services. And for the most part, they do a very good sales pitch in terms of what they can provide. However, being a solo practitioner, I have to be able to make myself stand out compared to not only any other solo practitioner, but these groups that are, I don't mean to be pejorative, but they're sort of infiltrating skilled nursing facilities and assisted living facilities. And so you have to really be a salesperson. You have to have some sort of a business model that is going to set yourself apart. And I've listed a couple of bullet points that have really served me well over the time that I have been doing this, which is now a little over 7 years. The first point that you're really going to want to emphasize with staff in these facilities is that you are a no-cost benefit to the facility, that you bill Medicare directly. And I bring that up. It may seem rather elementary to most people, but I have to tell you, the first facility I contacted back in 2010 was under the impression that they would be submitting billing for me under what's called a bundle billing with the skilled nursing facility, which I had no knowledge of. So I had to educate them that I'm independent and that it has nothing to do with the facility billing Medicare and being reimbursed, that I am completely independent, I'm a consultant, I do my own billing. The second bullet point is you want to emphasize that you will work with the nursing staff and specifically the social services staff to provide supportive services to the residents. The reason I bring this up is because, again, over the years, I have been in facilities where there have been other psychologists, and the other psychologists will literally come to the facility, see the resident, and leave, and not check in with nursing, not check in with social services, not have any sort of working collaborative relationship, which has been to their detriment over time, because I will go out of my way when I'm at a facility to check in on each floor. At the Los Angeles Jewish Home, one of the skilled nursing facilities is 5-story, one is 3 stories, one is 2 stories. And so when I'm seeing patients in skilled nursing, I make it a point to check in with the RN supervisor on the floor, to check in with the medication nurse, if possible to check in with social services, whether it's a social worker, a case aide, anyone that can provide me with some information to bring me up to date if anything has happened since the last session. At the Los Angeles Jewish Home, I also have access to the electronic health record, which is incredibly beneficial because I can then review charts before I go in to actually see patients, which is really nice. The third bullet point is you want to make sure that they know you're available to do something above and beyond the psychotherapy. So what I have done is I have provided staff-in services on mental health issues specifically to staff. So for example, dealing with compassion fatigue and burnout became a really big issue one year when we had, on one particular floor, we had 4 patients die and 2 staff members within, I think it was 3 months. It was like between Thanksgiving and New Year's. And it was really hard for the staff and the residents. And so the administrator asked if I would be willing to give some sort of in-service to help people to understand about compassion fatigue as well as burnout. And so I've been doing that for a couple of years now. The fourth bullet point is you're going to work as part of an integrated team to provide the residents with much needed assistance or adjustment assistance when they first move into the facility. And this is something that I pushed for back in 2012 when I was getting a lot of referrals for adjustment, for help with adjustment. And what I ended up doing was I ended up coming up with an actual support group outline, a 10-week adjustment group to help people moving into skilled nursing, whether it was from assisted living or their own home. And more recently, I've started doing it in assisted living as well. And it's incredibly valuable, and the facilities really appreciate it because the staff doesn't have the time to be providing one-on-one counseling, typically. They don't have that type of staff to resident ratio. And so if an outsider can come in and provide a service that is not only needed, but that will help the staff, then I guarantee you are going to stand out compared to other psychologists who literally come to a facility, see patients, and then leave. And then the final bullet point is within the past 2 years, I was asked if it was possible for me to provide supervision to the social workers at the Los Angeles Jewish Home who are seeking licensure in the state of California. And the supervision is specifically for the psychotherapy component of their hours. And I agreed because I really thought that was something I would enjoy to sort of balance out all of the clinical work and the trainings that I was doing. And so right now I feel like I'm getting the best experience possible because I do clinical work, I do supervision of social workers, and I give in-services and do some informal trainings with staff members. Once you have your foot in the door and you've sold your services and they are eager to bring you on board, what you need to do is you need to give an in-service. I strongly advise that you give an in-service from the get-go to nursing staff, social services staff, regarding how to help them identify residents that could benefit from psychological services. You have to sell them on your services. So even though the administrator or the director of wellness might have brought you on board, there may be other staff members that are going to be your greatest allies because they are going to know the residents even better on a daily basis. And so if you can give an in-service to describe not only why supportive psychotherapy is beneficial for older adults, such as increasing quality of life, helping them to gain coping skills, change negative thinking patterns, increase self-esteem, reduction of symptoms, et cetera, they're going to see the need for the referrals. They're going to identify residents that they know of who might be isolating in their rooms, who aren't going to activities, who exhibit symptoms of depression yet deny being depressed. And so the staff can then go and speak to the resident, tell them about the service that you can offer, and encourage them that it's a resource. And so far, knock on wood, I have not had a problem with getting referrals once the staff understand what it is I can provide and how I can actually help staff. The second bullet point is, in skilled nursing facilities, you're going to want to connect with whoever the director of social services is, and you need to find out whether or not a referral system is in place for making referrals to you. I bring this up because when I first came on board at all of the facilities I was at in 2010 after getting licensed, there was not a referral system in place. And so I would get these sort of Mickey Mouse emails, or from one facility they were texting me room numbers and or initials, and I said, whoa, no, we can't do this. This is a big no-no. And I came up with a form for referrals and presented it to the administrator and explained to the administrators and executive directors why that was necessary. It's not only necessary to help me understand a little bit about the reason for the referral and a little bit about the resident, but it's also for the facility to have a tracking system. Because if they get the order from the medical doctor and there's a communication breakdown and the resident doesn't get seen, there's no paper trail. And so it can be somebody's word against yours. And I just felt like there needs to be some system in place for everyone's benefit. So I came up with a referral form. I have both psychiatry and psychology on the form, so it's really more of a mental health referral form. And all of the facilities that I am at use it, and it's been incredibly helpful, I believe, not only for me, but for the social workers referring the residents, because they really have to explain the benefit as to why they're making the referral. The third bullet point is to be able to explain the benefit of providing supportive psychotherapy to short-stay or short-term residents, as these residents are often overlooked and can benefit immensely. These are the residents that come after, having a fall, after having a knee replacement, a hip replacement. And 7 years ago, when I started my practice, I was only getting referrals for long-term care for residents that were there indefinitely. And I approached the administrators and directors of social services because I had been approached by a family member of a short-stay resident who said, my father could really benefit from talking to someone. This is such a foreign environment for him. He's younger, he's very high functioning, and he's becoming incredibly depressed being surrounded by these older, sicker people. And so, again, being able to explain that to the administrator, to the director of social services, as well as the social workers and nursing staff, boosted my referrals. And it's been great to, again, have that balance. I see long-term care residents in skilled nursing. I see short-term care residents in skilled nursing. And I see long-term care residents in assisted living. I also see patients in an outpatient program, which I will talk about shortly. The next slide is probably why most of you wanted to attend this webinar. What is this part-time work with a full-time salary, Michigas? What does that mean? Well, it basically boils down to dollars and cents. I mean, there's no magic to this. In Southern California, Medicare reimburses roughly $106 an hour. So that would be the CPT code 90837. If the patient has a supplemental insurance policy, it kicks in another $27 plus or minus that you will be paid directly from that supplemental insurance policy. The reason I use the 1-hour session as an example here is because I only accept referrals for high functioning residents. I do not accept referrals for residents that have a diagnosis of dementia. I do not see patients on Aricept or Namenda, which are medications for memory loss. I do not see patients with cognitive impairment that has been at least identified by a healthcare professional or is obvious to staff. So again, I only see 20 patients a week, and I'm at multiple facilities, but I see 20 incredibly high-functioning people who could talk for a lot more than an hour if they could. But those are the patients I see, which is why I only do 20 hours a week, because they're very high functioning, and I feel like I can get a lot done in an hour and see them for a couple of weeks to 2 or 3 months, and we can resolve anything outstanding for the most part. And then I can transfer them to social services for supportive counseling. At the Los Angeles Jewish Home, the social workers, that is part of their role, is to do supportive one-on-one counseling. And because they are all getting licensed, this works out beautifully, that they can actually provide what I'm providing, but perhaps for less time, and to maintain the patient's stability over time after I've completed psychotherapy with them. The second bullet point is really getting to the nuts and bolts of what is it like to work part-time, and what constitutes a full-time salary. So I've just done some number crunching. So for example, I see 20 patients plus or minus in a given week, actually minus, I never see over 20. Medicare compensates me approximately $2,100 per week. And then within 2 to 3 weeks after submitting my billing to Medicare, I will collect an additional $540 plus or minus from the various supplemental insurance policies. So when you look at that number, you're looking at roughly $2,600 a week of income from working 20 hours a week. And when I say working 20 hours a week, I mean 20 clinical hours. I do not get paid for doing in-services, nor do I get paid for doing supervision with the social workers, and that's a personal choice. I feel incredibly grateful to the Los Angeles Jewish Home for basically building my practice from scratch back in 2010 and allowing me to work part-time with a full-time salary. And so this is my way of giving something back to the Jewish Home. The third bullet point is my monthly business expense, which for the past 7.5 years or so has been about $19.95 a month for Office Ally, which is a billing clearinghouse to bill Medicare. I use Google Voice for my business voicemail. That's free. I do not have them transcribe the voice messages. I know some people don't feel Google Voice is appropriate. I don't see it as a problem because I don't get transcriptions of my voicemail, so that means there's not some third party listening in and then typing up what they think the patient has left on my voicemail. I have no office rent. I have no office staff. Again, I do my own billing. So the other expenses that I have are pretty much in line with other psychologists, such as, licensing fees, which in the state of California is every 2 years, liability insurance, which for me is part-time, so it's a bit reduced from the full-time dollar amount, and continuing education expenses, or soon in California, continuing professional development. The last slide I have here, I call it the pros and cons, which I realize sounds a little harsh, so I want to call it the benefits and challenges to a mobile Medicare model. The benefits are they actually outnumber the challenges, but it doesn't look that way, but they actually do. So the first benefit is you have total autonomy over your practice. You don't have to go in if you don't want to. You don't have to work any number of hours that you don't want. You make your own schedule. You can do as much or as little work as you want. You really don't report to anyone. And you will get a lot of referrals if you are the only psychologist at a facility. So for several years, I was the only psychologist at one facility. And so I built up my practice because of that, incredibly quick, and realized that I could I could stop going to other facilities and just narrow my work down to 1 or 2, which is what I currently do. So on Mondays, Tuesdays, and Wednesdays, I'm at the Los Angeles Jewish Home, where I do outpatient therapy in their PACE program, which stands for Program for All-Inclusive Care for the Elderly. I see patients in assisted living at the Jewish Home, as well as skilled nursing. And then on Thursdays, I'm in Beverly Hills at an assisted living facility seeing patients at Sunrise Assisted Living. So now for the challenges. The challenges to a mobile Medicare model, other than having to drive from place to place, is you don't always have access to an office. So the only place I actually do have an office is in the PACE program. The Brandman Center for Senior Care provides me with an office on Tuesdays to see my patients there. But typically in skilled nursing and assisted living, you will not have a private office. One of the assisted living facilities at the Jewish Home allows me to use their conference room, which is nice. And then at Sunrise, everyone has their own apartment, so it's not an issue. But in skilled nursing, it can be an issue if they have a roommate. So sometimes it means having privacy or confidentiality issues. So your patient may have to negotiate with a roommate having the room to themselves for an hour once a week. Or if you can find, an open space with a door where you can have privacy, then you would go there. The other sort of challenge that I was faced with right from the get-go was Medicare requires a physical office address when you become a Medicare provider. Well, I was not about to list my home address, and I couldn't use my P.O. box, so I asked the administrator if it would be okay to have Medicare-related mail coming to the Los Angeles Jewish Home. And she said, absolutely, not a problem, we'll get you a mailbox. Which was great. However, Medicare lists that address. And so within a couple of months, I was getting phone calls from residents in the Reseda neighborhood of Los Angeles asking to make an appointment. And I couldn't figure out, how are people getting my number? I don't have a website, I don't advertise. And as it turned out, it's because Medicare has that as public record. And more savvy people with Medicare will then go online and look to find a psychologist in their neighborhood. The other issue that I had with having the Jewish Home as an address was I actually had people showing up physically. And the Jewish Home is gated and guarded. You can't even get on either campus without knowing someone or having an appointment. And I'll never forget the guard calling me on my cell phone one day saying, Dr. Forsay, you've got a patient here. What floor is this patient from? And, I quickly ran to the guard shack and said, I don't know this person. And come to find out it was just someone who wanted to make an appointment. So not having an office address can be a bit of you've got to figure it out, I guess is what I'm trying to say. The next thing is you can at times feel that there's a lack of a sense of belonging because you're not an employee. So you might hear about all of these things going on, right? They're having fundraiser lunches, they're doing employee dinners or parties or award ceremonies or whatnot, and you're not going to get an invitation. Now, that's not necessarily a bad thing, but for some people, because if you're at a facility daily or once a week and you really feel like you're a part of that organization yet you're not, it can kind of leave you feeling left out. And then the final part of the challenge that I face, not too often, but more often than I'd like, would be staff coming up to me and saying, Dr. Forsay, can I speak to you about something? I want to talk to you about my son or my daughter or my husband or whomever. And once staff gets to know you and trust you with regards to making referrals, that can carry over into them trusting you with their own personal information. So having boundaries is really important, and without offending anyone, it's important to let them know that you provide services to the residents and not to the staff. And so I guess we're open for questions if we have time, if I haven't gone over. And if you have any further questions, we've listed my contact information, and I would be happy to answer any questions. If we don't have time, feel free to shoot me an email with any questions you might have.
Hi, Dr. Forsay. Thank you
Hello.
so much. This is Jewel.
Thank you. Thank you.
And we have plenty of time for questions, which
fantastic.
is good because we have a lot of questions.
Oh, even better.
Yeah. So once again, to all our attendees, please, if you have any questions, type it into the chat box. Thank you for those of you who are being very patient with me as I try to make sure I get all your questions in line so that I can ask our presenter. So we will start with the first question. I thought this was a good one to start with. How do you afford health insurance?
So I have a domestic partner, and I am on his health insurance. He has excellent health insurance. He's a professor here at UCLA, and so that's how I do all of my benefits are through him. But I know that psychologists who are not in my situation that are looking, some of them have talked about Costco has health insurance, as well as other, insurance companies. But unfortunately, I can't answer that other than to say that I'm on my partner's health insurance plan.
Okay, thank you. Our next question is about CPT codes. What CPT codes do you use to conduct a behavioral analysis and to complete a behavior management plan for residents with advanced dementia and BPSD?
So as I stated, I actually don't see patients with dementia, so that's never a part of the CPT codes I use. I literally only use 90791 for initials and then 90837 for the weekly and or every other week psychotherapy. Now, that's not to say that sometimes I can see a patient and they have an appointment they have to go to, so we cut the session short, and I will use 90832 or 34. But I don't do the other the question that you asked with regards to PTSD or dementia at this time.
I guess it's, sorry everyone, I'm not a psychologist. B as in boy, PSD? Is that a thing?
I don't know what that means. BPSD? Okay. I don't know that term, unfortunately.
Okay. The next question, are you able to bill for InServices, and how?
I've never billed for them. The facility actually pays me. So I was paid, let me see. The two facilities I'm at now do not pay me. Previously, in a past life, several years ago, I was paid for InServices, and that I charged $150 an hour, and that was back in 2011, 2012, when I was trying to build up my practice, and felt that I wasn't at a point where I could actually give it away for free because I was again, trying to build up my practice, and I wanted them to see that there was value in what I had to offer. So back then it was $150. It would be a little more now. But I think that's also demographic specific. You know, here in LA County, Los Angeles County, you know, psychologists can charge $200, $300, $350 an hour for psychotherapy. So facilities may be comfortable paying a portion of that to do an in-service, whereas in other parts of the country, it may not, you know, the average hourly salary may not be that high, or hourly rate may not be that high.
Great, thank you. Ready for another question?
Absolutely.
All right, so do you provide all those extra services, supervision, consultation, et cetera, at no cost, or do you work out separate agreements?
No, that's correct. Currently, well, for the past, yeah, at the facilities I'm at, it's free. And, you know, again, that's because I'm really only at 2 facilities, or 2 organizations, Sunrise of Beverly Hills and then the Los Angeles Jewish Home. And the Los Angeles Jewish Home I've been at for over 7 years, and they have really, as I said, they have built up my practice. You know, initially I was only in skilled nursing, then they had me see assisted living. I also see patients in the Geropsychiatric unit. And now for the past couple of years, I've been seeing patients in the PACE program, which is an outpatient program where community dwellers turn their Medicare benefits over to the PACE program, and then they come in to one place for all of their care. It's sort of like adult day health care, but they can see all of their providers in one fell swoop, and transportation's provided, meals are provided. So that would be, it's actually something I unfortunately left off to discuss, is as people are interested in doing this mobile Medicare program, you might want to check if there is a PACE program in your state, because until I was brought on board, I was told there were no psychologists, to the best of their knowledge, in any of the programs in California. So that would be some other, another venue to investigate, and you have to be a Medicare provider as well to see their participants.
Okay, what type of charting program do you use, and how do you ensure that you are meeting Medicare's requirements for content of note?
Okay, so I actually have a template, and I hindsight's 2020. I should have included it in the PowerPoint. If anyone wants that, I'm happy to share it with you. It's not any great template, but I do use it, and I believe it meets all of the criteria for, at the time, it was Palmetto that was our Medicare administrative contractor when I became licensed in 2010. And so they had what was called a local coverage determination, or an LCD, that was specific for mental health. And so I used that information to formulate a template that would then cover all of that. So if anyone wants that, please shoot me an email. I'd be happy to send it to you so that you could see.
Okay, I kind of have a 2-part question here. One of our attendees asked, how do you work confirming approval for Medicare for 90837 and for the diagnosis you give? They really want the nuts and bolts of that.
I'm sorry, can you repeat the question? How do I confirm the 90837? Is that what you said?
Yes. And the diagnosis you give, making sure that the diagnosis code is one Medicare pays. And
so, okay, sure. So in Office Ally, it's a great question. In Office Ally, when you're actually doing your billing, they will tell you whether or not the code is kosher for being reimbursed. So again, I think the diagnoses that are going to be questionable to Medicare, or in Southern California, Noridian, are going to be the ones that have any sort of component of cognitive impairment. Now, that's not to say that you cannot do psychotherapy with people who have mild cognitive impairment, or even people with a formal diagnosis of dementia, because it may be that they're at the initial stages. But I don't accept referrals for that very purpose. I have never had any issue with Medicare. I've never had an audit. I've never had any payment get denied. I've never had any issue, but I've also never seen patients where there has been a question whether or not the patient could benefit from psychotherapy, let alone 1 hour. So I hope that answered the question.
Okay, thank you.
Sure.
The next question is, I thought that with Medicare, you had to establish a site and location for each place you see clients. Has that not been your experience? When you do the application for Medicare, it does ask if you are at other, I believe if you have other offices or other locations. And so the office that they publish for me is the Los Angeles Jewish Home. Now, historically, back in 2010, when I became a Medicare provider, at one point I was at 7. So I had to keep logging into PICOS, updating my addresses. When I would leave a facility, I'd have to go back into PICOS, take it out. So the question is accurate. You do have to, I believe, unless things have changed, in PICOS, when you are going in to change your office location or add office locations, you are supposed to list exactly where you're at. And that goes hand in hand with when you do your billing, you actually have to list the facility where you saw the patient. So that's correct. But Medicare only, I believe, for me anyways, they only show the Los Angeles Jewish Home as my practice address. Okay, so this question kind of ties into that. How do you deal with the patients, with the potential patients who call for an appointment at the nursing home address? My understanding is you cannot refuse at least an initial appointment.
That's not correct. I don't have an office, so I cannot have, I don't think the nursing home or the assisted living facility would welcome someone coming onto their property for an initial evaluation. I just don't think that would happen. And I don't think that I'm obligated to see anyone that calls. I believe we can pick and choose which patients we see. And because, you know, by default, I don't have an office, so I can only see people who are living in the facilities where I provide services. So to answer the question, how do I handle it if people call, I return the call and educate them, and let them know that while I am a Medicare provider, I am what is called a facility-based Medicare provider, and that I see, you know, residents of skilled nursing, assisted living, and it hasn't been an issue. I also, when I have them on the phone, typically when I return those calls, I'm near a desktop computer, so I can access the Los Angeles County Psychological Association's website because we do have a directory. So I will ask, you know, what is your insurance, what is your zip code, and I try to give them referrals for who they can contact that would, you know, have an office where they could be seen. And so that's how I would handle that.
What do you use for your EHR?
I don't have an EHR, so I have a template that I use for all of my notes. I store them on my laptop and transfer them when I get home to a computer that is not hooked up to the internet, and that's where they stay. And then at the Los Angeles Jewish Home, they scan my notes into their electronic health record, which is called Achieve Matrix, which I have access to from home. I can log in. But I don't have an electronic medical record, health record system that I use. I know Office Ally has one, Practice Fusion has one, but I don't use them.
Okay, great, thank you. We've got some more questions, so I hope you're ready.
Oh, we've got 15 more minutes. Bring them on.
Yeah. All right, so how long is the time before payment for services?
So with Medicare, it's 15 days from the day you upload your billing to Office Ally. So for example, if I upload billing today, I know that in 2 weeks and 1 day, that amount of money that I should be paid will be direct deposited into my checking account. So it's very nice. From the time you upload the billing, it's 2 weeks and 1 day. Supplemental insurance takes a little bit longer. And with supplemental insurance, if you don't have it set up for direct deposit, which typically takes at least getting one check in the mail first before you can set up direct deposit, supplemental insurance will go to your practice address. So I get a lot of mail at the Los Angeles Jewish Home by virtue of my supplemental insurances, which is AARP, Blue Cross Blue Shield, TRICARE, whoever the supplemental insurance is, and that can take anywhere from 2 additional weeks to whenever.
All right. This is an interesting question. How are you preparing for the shift away from fee-for-service reimbursement?
I'm not sure I understand the question because I didn't know we were shifting away from fee-for-service for Medicare. Are they talking about MACRA, or I'm not quite sure I understand the question.
They could be. I guess another question that ties into that is, if you don't use EHR, how do you plan to survive MIPS, or are you willing to take payment deductions?
Okay, that's a great question. When and if there's incentive to do EHR, I will be the first one on board. But for right now, because I don't see the benefit yet, I'm just continuing to do it, on my laptop, print it out, give it to the facilities, and then transfer it to my computer that's not hooked up to the internet to store it on, and then have a backup disk.
Okay. Kind of related to that, what is required to qualify as a Medicare provider?
My understanding is you just need to have a doctorate and be licensed in the state where you live. There's not. I tend to believe Medicare is the easiest panel to get on and the quickest. And once you are in the process of getting paneled with Medicare, or I don't know if that's the correct verbiage, you can actually see patients because you can back bill 30 days from the time that you actually get your PTAN, your physician transaction number, which is what you use when you bill. So that's a great question, because I think there's a lot of myths or out there about what it means to be on Medicare, in terms of how do you get credentialed.
Great, thank you. And I want to thank my attendees for helping me out. Someone said that BPSD equals behavioral and psychological symptoms of dementia.
Oh, okay. Okay.
So we have a question on that. Can health and behavior code, CBT codes, be used with dementia patients presenting problems of BPSD?
I would guess the answer would be yes to that, because you can be called in to do, what are called non-pharmacological interventions for patients, that have behavioral disturbances, and specifically people with dementia. My guess is you would be reimbursed. Again, that's not a population that I work with. But there are articles out there. In fact, there's one on Annals of Long-Term Care recently that was about specifically behavioral interventions, non-pharmacological behavioral interventions.
Okay. Do you need to have specialized training in geropsychology to do this type of work?
My answer is going to be yes. I don't know that people are going to like hearing that. And the reason I say that is because with more and more groups bringing psychologists into these facilities, my understanding is they don't really require anything other than a doctorate and a license. And, there's a difference between doing art therapy with children and doing geropsychology with older adults. And I've seen in facilities where there have been other psychologists that there have been issues that have come up, where patients have complained, family members have complained, saying, what is this person seeing my mom weekly for? I don't think that she knows what she's doing, or whatever the situation is. And then come to find out, the psychologist is doing therapy with an older adult that is not, appropriate. It's not the standard of care in geropsychology. So I would say yes. Take some continuing education courses, get some books on geropsychology. Take a course if you can at a local graduate program or school, adult education, whatnot. Because there are some very specific things about treating older adults that are specific to older adults. Whether it's adjustment, acceptance, to moving into a facility, downsizing, dealing with grief, dealing with loss, that are, just they have a particular nuance that, doesn't really translate to working with children or teenagers or young adults.
Thank you. And we have time for one more question. How do you manage your own compassion fatigue?
That is a great question. How do I manage my own compassion fatigue? Well, thankfully, I don't feel that I have it. Compassion fatigue is just really, it's empathy is what it is. It's where you're just burnt out. You're giving it all away, and what you need to have is, compassion satisfaction. I think it's about knowing, having good boundaries. It's about understanding what it means to have compassion fatigue, what to look for, what are the signs, what triggers it, and then trying to offset it. I'm very active here in Los Angeles. I play polo. I have horses. I play polo. I volunteer. I guess I look at my work as work, and that's a part of my life. That's my professional life, and then I have my personal life with my partner, and outside of facilities, outside of older adults, and so I guess that's just how I look at it. Maybe it's because I know about compassion fatigue and burnout that I'm constantly mindful of what to look for and then what to do when I feel it coming on. And knock on wood, so far I haven't had that problem. But I think it's a great question, because a lot of people that work with older adults, it's very easy for that to happen, whether you're a nurse, a social worker, a psychologist. It could manifest as just being sick, physically, having a physical reaction. It could be that you're lashing out, short-tempered, calling in sick, not wanting to go to work. And I think it's just important to have someone to talk to about that as well, so that you can, not feel like it's you, but that there's actually a reason why,
Okay. Just one more question. We have time to get to one more question. I want to make sure I get as many in as possible. What books or articles do you recommend for doing psychotherapy with this population?
Oh, my goodness. I have 3. I have a bookcase, 3 shelves. It's all geropsychology. Let me just look really quickly. I would strongly advise the Treating Late Life Depression by an old professor of mine, Larry W. Thompson, and his wife, Dolores Gallagher Thompson. They have a workbook and the therapist guide. That's an excellent resource. Handbook of Assessment and Clinical Gerontology, I actually like. There's Cognitive Behavior Therapy with Older Adults by Kristen Sirocco and Sean Lauderdale is a good book. What else? These are some of my newer ones. Geriatric Mental Health Ethics by Shane Bush. Handbook of Behavioral and Cognitive Therapies with Older Adults, and that's by Dolores Gallagher Thompson, Ann Steffen, and Larry Thompson. There's also treatment planners, so the practice planners, the Older Adult Psychotherapy Treatment Planner. I believe there's also a workbook or a homework treatment planner. I recently bought a book called Transforming Long-Term Care, which is very interesting about the roles of psychologists in long-term care. And then I also bought the DSM-5 Pocket Guide for Elder Mental Health, which is by a medical doctor, Sophia Wang, and Abraham Nussbaum.
that is an amazing guide to the DSM for working with older adults. And those, you know, again, I've got 3 shelves here, but those are the ones I would definitely recommend. And then APA last year came out with the APA Handbook of Clinical Geropsychology, and that's 2 volumes, two very big hardback books. And those are excellent as well.
Great. Thank you so much. This webinar was incredibly interesting. And thank you to all of our attendees and all of the wonderful questions you submitted. We will hopefully have Dr. Frise follow up some of these questions and answer them either in a practice update newsletter article, or if you liked this webinar, we can maybe invite him back to do another one.
Absolutely.
Thank you so much. Everyone who signed up for this webinar will be getting a recording and a survey to take, so please let us know what you think about the webinar. And you can continue submitting questions by emailing them to practice@apa.org. And again, Dr. Frise's email is michaelfrise@gmail.com. And you can find additional information about Medicare on our website at apapracticecentral.org. And if you received one of our earlier issues of Good Practice magazine, you can read tons more about how Dr. Frise started his practice and became a mobile Medicare provider. Okay, so that's all we have for you guys today. Thank you so much for signing up, and we hope to see you all at our next webinar in October.
Thank you so much.